Hello, welcome back to Atropia Medic School. This is the second in a two-part video series on pharmacology. If you are just coming across this, go watch the first video. We explain some pharmacology stuff there, or just start with this video and then go back and watch it later. I don't really care what you do. The more you know. Moving on, let's look at the questions. All right. Aspirin has which mechanism of action? A, it is an anticoagulant. B, it acts to inhibit platelet aggregation. C, it is a vasodilator. Or D, it is an opiate receptor agonist. So take a moment to think of your answer. And we're looking here at answer B. So let's talk a little bit about aspirin. Aspirin is a few things, actually. We know it very commonly as an NSAID, a non-steroidal anti-inflammatory drug, similar to things like ibuprofen or naproxen, aka Aleve, ibuprofen, trade name Motrin. We all know it. We all know it and love it. Not to be confused with Tylenol or acetaminophen. That is not an NSAID, just FYI. But anyways, it falls into the NSAID family. And the big thing that aspirin has is, aside from like the anti-inflammatory effects, is also it has unusually high amount of platelet aggregation inhibition, meaning it prevents platelets from sticking together. Now, if you remember back to your hematology lectures, which at the EMT level should not be very extensive because it's not super important for most things that we do at the EMT level, you probably remember platelets are kind of like the first responders for bleeding control. So when we have injured blood vessels and tissues, they release chemicals that signal to platelets, hey, come here and fix me up. The platelets glue themselves together to that hole, they kind of plug it up, form a scab, and then over time, what also happens is clotting factors will get mobilized to reinforce and pull all that injured tissue back together, really closing down that wound, and over time it starts healing from the inside out. So why do we want this? Why do we want to inhibit platelets? Well, when we think about someone who's got like ischemic chest pain, so we talked in another video about like classic cardiac chest pain, classic ischemic chest pain, or acute coronary syndrome. This is where I start to think, hey, you know what? We need these platelets. Why is that? What happens, let's draw out a blood vessel, actually. Let's do that in red. So let's say this is my blood vessel. And let's say in yellow, I get a lot of plaque. I have plaque buildup. It builds up on the inside, but over time, it can build up on the outside as well and balloon out or balloon inward some of the inner lumen of the blood vessel. So eventually what happens is we start injuring that inner layer and we start breaking it open because we have more and more plaque building up. Well, guess what? We now injured the blood vessel. So what comes in? We'll kind of do that in, let's choose purple. Purple's a good color. So now we got all these little platelets that are starting to glue themselves to that injured blood vessel. And remember, when I get one platelet gluing itself to that injured blood vessel, it will signal other ones too as well. And then eventually we turn a partial occlusion into a full occlusion. This is why it's important to give someone aspirin when they're having that ischemic or classic cardiac chest pain. Now, when we talk about vasodilators, big one we think of is something called nitroglycerin. A lot of other medications function as vasodilators as well, but nitroglycerin is probably our big one. Excuse me. Not in the least because we can help patients take their own nitroglycerin. D is an irrelevant answer. That's, well, opiates. That's your, painkillers, oxycodone, morphine, things like that. A lot of people mix up aspirin's effects with the effects of anticoagulants. So what anticoagulants do is they actually inhibit clotting factors. So clotting factors and platelets are complementary, but their signaling mechanisms are a bit different. So I can give someone aspirin and it doesn't really radically affect the clotting cascade. It doesn't affect clotting factors. Likewise, if I give someone an anticoagulant, it doesn't necessarily inhibit the ability of platelets to do stuff. Now that said, at some point you can it can eventually start affecting other things if you take too much, but that's a story for a whole other time. But again, these two clotting anticoagulants in NSAIDs do they complement each other in preventing like clot formation or preventing platelets from sticking to one another? They're complementary, but they are two different things. Anticoagulants do not affect platelets, and the NSAIDs, especially aspirin, don't affect the clotting factors. All right, moving on. Actually, let's move down first. Since we're talking about aspirin, which of the following are relative contraindications to the use of aspirin? A, history of GI bleeding. B, asthma. C, coagulation disorders. Or D, all of the above. So spend a moment, pause if you need to, pick an answer. And we're looking at D, all of the above. So aspirin is a funky medication in that other than a true anaphylactic or significant allergic reaction to the drug or to the class of medications, most of the other contraindications are relative, meaning they're situational. So to start off with GI bleeding, they can have a history of GI bleeding, but as long as they do not have an active GI bleed, so no active GI bleed. So make sure that you ask a patient if they mention a history of GI bleeding, hey, do you have an active GI bleed right now? Or are you being treated for an active GI bleed right now? If they're being treated for it, okay, obviously we don't want to give them aspirin because it can make it worse. But if they just have a history of it, we're not. The benefits outweigh the risks at that point. Now, with asthma, there is something called Samter's triad. Samter's triad. This is not a high-yield topic, but I just want to explain it just so you're aware that it's a thing. With asthma, sometimes about, I think, 15-20% of asthmatic patients can have reactions to aspirin. I'm not entirely sure about the pathophysiology behind it, other than it has something to do with like prostaglandin inhibition or whatnot. But some asthmatics will have bronchoconstriction related to aspirin use. So you always need to ask, like, if you have a patient with a history of asthma and they're presenting with like acute coronary syndrome like symptoms, always ask, hey, have you ever taken aspirin before and had any issues with it? With coagulation disorders, we think about more so, we think of things like, do they clot unusually easily, or do they take a long time to form clots? So are they hypercoagulable? We'll write some of these words down. Are they hypercoagulable? Or are they hemophilic? If I have a patient with a history of hemophilia, I would be a little concerned just to give them aspirin, just knowing how they have this major predisposition to bleeding. We also are a little cautious about giving aspirin to someone who's on a blood thinner or an anticoagulant like warfarin, Coumadin, apixaban, Eliquis, things like that. But that's a relative contraindication. There's nothing specifically stating we cannot do it. There's just more risk to doing it. But again, clotting factors are not affected by aspirin. Likewise, anticoagulants do not affect platelets directly. So someone who's having acute coronary syndrome type issues, they should still get aspirin, but we need to just understand that there's going to be more bleeding risk with it. All right, next question. A diabetic patient presents with polyphagia, polyuria, and polydipsia. You also note a fruity smell on the breath, and the patient is ANO times 1. The respiratory rate is 24 and deep. You should A, administer oral glucose, 15 grams. B, insert an MPA. C, administer BVM ventilations. Or D, obtain a blood glucose level. So spend a moment, pick an answer. And here we should just obtain a blood glucose level. So they don't mention anything specifically about the patient needs BVM ventilations. I know the rate is elevated. I know the respiratory quality is deep. That sounds pretty... I'll take it. I'll take someone who's breathing deeply. This is a very common thing to see in someone who is in diabetic ketoacidosis. Their blood is literally acidic due to the buildup of ketones, which is a byproduct of shifting away from glycolysis into ketosis from the breakdown of like fats and proteins. But anyways, more importantly, we have someone who's adequately breathing, so we don't need to do a BVM. They're ANO times 1, meaning that they're alert, more or less. Not fully alert, but they're at least awake. So there's really no point in giving them an NPA. And then without knowing the symptomology here, right? Polyphagia, polyuria, polydipsia. That's what we call the 3 Ps of hyperglycemia. And the NREMT does like to test on this. So knowing that these are a part of a triad that indicates to us this patient's probably hyperglycemic, chances are we don't really need to give them oral glucose. Now, would it necessarily harm them if we gave them oral glucose? The answer is it won't radically change anything, but why give them a medication we know is not going to benefit them? So let's actually see how high that blood glucose level is so that we can confirm that this is what we think it is. All right, let's look at our next question here. You have a 34 kilogram pediatric patient experiencing an anaphylactic reaction. Which of the following is the correct dose? A, 0.3 milligrams, 1 to 10,000. B, 0.15 milligrams, 1 to 1,000. C, 0.3 milligrams, 1 to 1,000. Or D, 0.15 milligrams, 1 to 10,000. So pause if you need to think about it. Take a moment, pick an answer. And we're going to pick C. And I'm sure some of you are going to be freaking out a little bit. And you're like, oh my gosh, Atropia Medic. Like, this is a pediatric patient. We need to give them pediatric dosing. Let's talk a little bit about epinephrine. A couple warnings about epinephrine. One, it comes in different concentrations. We always use 1 to 1,000 concentration. Super important. So always check your medication. And before someone says, oh, we use EpiPens, more and more places are having their EMTs draw everything up out of a vial and actually stabbing the patient with a needle. So no, the days of we're just going to rely on EpiPens or auto-injectors are kind of going to the wayside because they're so darn expensive. Now, the other thing to note about epinephrine for dosing purposes, if we have a pediatric patient, peds, let's talk about peds for a second. If we have a pediatric patient under 30 kilograms, generally speaking, we're going to use the pediatric dosing, which is 0.15 milligrams, 1 to 1,000. You'll sometimes see some protocols write this as 0.01 milligrams per kilogram, adding even more math into the mix. But standard dosing is usually around 0.15 milligrams. Now, what if they are at that 30 kilograms or above? Well, we're just going to use the adult dosing at that point. They're big enough to handle that adult dosing. It doesn't really matter. We never exceed the adult dose, even if we had we'll say a hefty pediatric patient. Regardless, we don't exceed the adult dose. Now, another thing to warn about from a test taking perspective is they do ask questions like this where they will give you a weight and they expect you to know either it's above this cutoff or it's below this cutoff, and they want you to pick the appropriate answer for that. Also note how we have a bunch of answers that look very similar with something just slightly different about them. Again, do your due diligence. Make sure you're reading through everything thoroughly before you pick an answer, because it's really easy to zoom through this, not pay attention, and then you get a wrong answer. So just remember, if you have a patient who is 30 kilograms or more, and we're talking about pediatric patients here, 0.3 milligrams. That's just carte blanche. And then if they are under 30 kilograms, your pediatric patient should get 0.15 milligrams, so like the pediatric EpiPen, or if you're vial drawing it and your protocols want you to do it this way, some protocols write it as they want you to give 0.01 milligrams per kilogram. Fun stuff. All right. Next question. You have a 6-year-old who drank an unknown amount of bleach. The patient is crying and has abdominal pain. You note that the patient is otherwise stable. You should not: A, administer activated charcoal; B, obtain a sample history; C, call poison control; or D, transport to a pediatric hospital. So pause if you need to, spend a moment thinking about your answer. And here, we are actually not going to give activated charcoal. So activated charcoal, or sorbitol, as you might hear it, is it's essentially like burned breadcrumbs, if you will. It's actually kind of like a sugar bait. It's a carbohydrate, if you will. And what it does is it kind of acts like breadcrumbs and absorbs stuff in the GI tract. And theoretically speaking, we use activated charcoal for someone post toxic ingestion, particularly a lot of medications. So if a child, or an adult for that matter, ate a bunch of things that they should not have eaten, like took a bunch of pills they should not have taken or whatever, we can use activated charcoal to absorb a lot of that stuff, and then we just pass it through the GI tract without it getting absorbed into the bloodstream. Now, the big contraindication to activated charcoal is caustic substance ingestions. So gasoline, bleach, ammonia, anything that is a strong acid or a strong alkaline, of which bleach is a strong alkaline and can actually cause burns to the airway and the GI tract. Activated charcoal is contraindicated in that patient. Now, with any, whether intentional or unintentioned ingestion, things that are good to do for that would be call poison control. Go figure. And even if there's nothing that poison control can do for you specifically, getting the information from poison control as to what the hospital may need to do in the immediate future, it saves the hospital a step. You have everything good, all the information they need to start initiating treatment. So even if you can't do anything with the information, it's still a great idea to call poison control. Always obtain a sample history. Go figure. Again, because this may be, sure, this is an ingestion, but maybe there's some other stuff going in the background that need to be addressed. For example, what if we have a patient who ingested a ton of pills and this was, a attempt at taking their own life, and there's like just unaddressed psychiatric issues going on, right? We want to provide those services to them, or at least help them get those services, things like that. Any pediatric patient ideally should go to a hospital that has the ability to take care of pediatric patients. Obviously, not every hospital has this, but in your area, wherever you work, you should be familiar with what hospitals have a pediatric ER, or at least have a pediatric physician who can come in and actually take care of patients at least. So all three of those, B, C, D, are things we want to do. A is contraindicated because this is a caustic substance ingestion. All right. Last question here. You have a 20-year-old patient who is apneic, unresponsive, has a carotid pulse, and is pale, cool, clammy. Which of the following medications would be indicated in this patient? A. Naloxone, 2 milligrams intranasal. B. Glucagon, 1 milligram intramuscular. C. Oral glucose, 15 grams transbucally. Or D. Albuterol, 2.5 milligrams intranasally. So spend a moment, think of an answer. And our correct answer here is going to be A. So without really going into too much detail about opiate overdoses, we know that respiratory depression is a big thing here. Now, this patient being unresponsive, it could be a diabetic issue. It could be an opiate overdose. It could be some sort of like cardiac thing. Who knows, right? We don't really know. But we do know that some of these other answers are pretty silly. So albuterol, 2.5 milligrams, that's actually it's normally 2.5 milligrams in 3 milliliters of fluid, and we nebulize it. But D is wrong because we don't do it intranasally. Now, we have an unresponsive patient. We should not be giving them oral glucose. If it was a diabetic issue, you would need an ALS provider in order to provide those other modalities to treat the blood sugar issues. Same thing here with glucagon. This is not a BLS medication. This is available at the ALS level, which is a discussion in and of itself. But we should not be giving medications or picking answers that we know are not in our scope of practice to do. So we're kind of left with only one thing here. Let's give them Narcan. And anyone who's apneic and unresponsive, we should, in our differential diagnosis, have an overdose of some variety, in the back of our heads, especially, a younger patient. That's very strange. I'm not thinking heart stuff necessarily at that point, but all those things should be in our differential. So that's our 6 questions for Pharmacology 2. At some point, we'll kind of elaborate and expand on some pharmacology stuff in future videos, but we'll leave it here today. If you like the content, please subscribe. If you have suggestions or ideas for future videos, absolutely leave a comment below, and we'll see you next time.